Today, we're diving into Guillain-Barré Syndrome. It's a really rare disorder where your body's immune system, your own personal bodyguard, suddenly goes rogue and starts attacking your nerves. This can lead to rapid weakness and sometimes even paralysis. And the scary part, it can all happen in just a matter of days. So how does it start? Well, for many people, it begins with this really bizarre sensation. They describe it as having rubbery legs. Imagine that. It's often that first strange feeling of weakness or tingling that kicks off a medical mystery that doctors have to solve, and solve fast. All right, so here's our game plan for unpacking this. We'll start with how it all begins, then we'll look at the different forms it can take. We're going to dive into how the body actually attacks itself, follow the clues doctors use to diagnose it, and finally, see how patients can fight back. Okay, let's get right into it. The onset. So what exactly is Guillain-Barré Syndrome? Well, its formal name is an acute inflammatory autoimmune condition. The word you really got to focus on there is acute. That means it hits hard and it hits fast. So GBS zeroes in on your peripheral nerves. That's the massive network of nerves outside of your brain and spinal cord. And like I said, its onset is incredibly quick, usually developing in less than 4 weeks. And while, it can really affect anyone, we do tend to see it a little more often in men, with the average age of onset hovering right around 40. Now here's where it gets really interesting. GBS isn't just one single thing. It actually shows up in several different forms, and each one has its own unique personality. So let's meet the 4 main suspects in the lineup. Think of GBS as a family of related conditions. The most common one, the one you hear about most, is AIDP. Then you've got AMAN and AMSAN, which are a bit different because they attack the nerve's core, the axon itself. But the one that's a real standout, a total curveball, is Miller-Fisher syndrome, or MFS. Yeah, MFS is the odd one out because it completely breaks the rules. It doesn't start with weakness in the legs. Instead, it's defined by this very specific trio of symptoms that makes it totally distinct from all the other forms of GBS. And here it is, the classic triad. First, you get ophthalmoplegia. That's a fancy word for paralysis of the muscles that control your eyes. Second is auroflexia, which is a total loss of your deep tendon reflexes. Like when a doctor taps your knee with a hammer and your leg kicks. Yeah, that just stops. And third is ataxia, a major loss of balance and coordination. See these 3 together, and you're almost certainly looking at MFS. So this all leads to the central question, right? What is going on here? How does your body's own defense system get so mixed up that it starts attacking you? Let's dig into how this attack from within actually happens. Your immune system is supposed to be your greatest ally, fighting off germs and viruses. But in GBS, something goes terribly wrong. It's a case of mistaken identity, where it sees your own cells as the enemy. So what could possibly trigger this kind of friendly fire? Well, in most cases, it turns out the trigger is a recent infection, something as common as a stomach bug. The #1 culprit is a bacterium called Campylobacter jejuni. Your body does exactly what it's supposed to do and creates antibodies to fight it off. But here's the problem. Parts of that bacteria look shockingly similar to parts of your own nerve cells. So after the infection is beaten, those antibodies stay on high alert and mistakenly start attacking your nerves instead. The best way to picture this is to think of your nerves as electrical wires. They're wrapped in this protective insulation called myelin, which helps electrical signals travel super fast. In GBS, the immune system's attack literally strips that myelin coating away. And without it, those nerve signals slow way down or just stop altogether. And that's what causes the weakness and paralysis. And the attack is pretty specific. It primarily goes after 2 types of nerve fibers. First, the A-alpha fibers, which are the big ones that control your muscle movement. That explains the weakness. It also hits the B fibers, which are part of your autonomic nervous system. That's the system that handles all the stuff you don't think about, like your heart rate and blood pressure. And that's why you see all that instability with GBS. Okay, so with all this chaos happening inside the body, how in the world do doctors figure it all out? Well, diagnosing GBS is kind of like being a detective. You have to follow a trail of clues that the body leaves behind. The biggest, most classic clue is the pattern of the weakness. It's almost always ascending. It starts down low in the legs, those rubbery legs we talked about, and then over the next few days, it literally climbs up the body into the arms. In the most severe cases, it can even reach the brainstem, affecting the muscles in your face and eyes. When a doctor does an exam, they're looking for a few key signs. The main one is this mouthful: bilateral areflexic flaccid paraparesis.
I know, but all that really means is weakness on both sides of the body at the same time, along with a total loss of reflexes. They'll also be on the lookout for those autonomic symptoms, like a heart rate that's all over the place. And interestingly, while there's tingling, major sensory loss is usually pretty mild.
So, the physical exam and the patient's story can give doctors a really strong suspicion. But to be absolutely sure, to confirm it, they have to go beyond what they can see and run some very specific tests.
Two tests are absolutely critical here. First, nerve conduction studies. These basically measure how fast electrical signals are moving through the nerves. And in GBS, since that myelin insulation is damaged, the signals are super slow, giving an abnormal result. The other huge test is an analysis of the cerebral spinal fluid, the fluid around your brain and spinal cord, which they get from a spinal tap. And inside that spinal fluid, they're looking for a classic telltale sign called albuminocytological dissociation. It means that the protein levels in the fluid are sky high because all that myelin is breaking down and shedding protein, but the white blood cell count, which would normally signal an infection, is totally normal. Finding this is like the smoking gun for GBS. So once that diagnosis is confirmed, it is a race against the clock. The goal is to shut down the immune attack as fast as possible to stop any more nerve damage and begin what can be a very long road to recovery. There are two main treatments that are used to fight back. The first, and usually the best option, is intravenous immunoglobulin, or IVIG. This is where they infuse a huge dose of antibodies from healthy donors. The idea is to basically flood your system with good antibodies to distract and neutralize the bad ones that are causing all the damage. The other option is plasma exchange, which is sort of like dialysis for your blood. It filters out the patient's plasma and the harmful antibodies with it and replaces it. Now, to really solidify our understanding of GBS, sometimes it helps to look at what it's not. And by comparing it to a related but very different condition, we can really highlight what makes GBS so unique. And that other condition is called CIDP. Let's put them side by side. The biggest difference is time. GBS is acute, it hits fast, in under 4 weeks. CIDP is chronic, with a relapsing remitting course over months or years. An infection usually comes before GBS, with CIDP that's pretty rare. Also, CIDP often has more sensory symptoms, and it's treated with steroids, which, by the way, do not work for GBS. This comparison really drives home just how distinct Guillain-Barré is. You know, when you step back, Guillain-Barré Syndrome is just this incredible and frankly humbling reminder of the sheer power and complexity of our own bodies. It shows us the razor-thin line our immune system walks every single day, and it leaves us with this final thought. What does it really reveal about our own biology that the very system designed to be our greatest protector can, with just one wrong turn, become our most formidable foe?